start our discussion with drug dosing in elderly. Defining elderly is difficult. The geriatric population is often arbitrarily defined as patients who are older than 65 years old, and many of these people live active and healthy lives. In addition, there is an increasing number of people who are living beyond 85 years old who are often considered as older elderly population. The aging process is more often associated with physiologic changes during aging rather than purely chronological aging. So, chronologically, the elderly who have been classified as the young old who are aging between 65 to 75 years, old who are at the ages between 75 to 85 years, and old who are above 85 years. Performance capacity and loss of homeostatic reserve decreases with advanced age but occurs to a different degree in each organ and in each patient. Physiologic and cognitive functions tend to change with aging process and can affect compliance, therapeutic safety, and efficacy of a prescribed drug. There is a decrease in cognitive function in some geriatric patients. Complicated drug dosage schedule and a high cost of a drug therapy may result in poor drug compliance, resulting in lack of drug efficacy, possible drug interaction, and even drug intoxication. So, the physiologic changes due to aging may necessitate some special considerations in administering drugs in the elderly. For some drugs, an age-dependent increase in adverse drug reaction or toxicity may be observed. This apparent increased drug sensitivity in elderly may be due to pharmacokinetic and or pharmacodynamic changes. Okay, so we'll discuss these things one by one. We'll start with the pharmacokinetics, and you know what happens in pharmacokinetics. We'll come across the four important members of the pharmacokinetic, that is absorption, distribution, metabolism, and excretion. First of all, absorption. Conditions associated with age that may alter the rate of absorption of drugs are altered nutritional habits, greater consumption of non-prescription drugs, changes in gastric emptying, slower in older persons. See, in reality, when elderly person takes medication, absorption isn't affected significantly. But what is important is actually other stuff they take that affects the absorption. Like the first thing it is written, altered nutritional habits. The old age people may be like, I want to eat some snacks, I want to eat some bhel puri, pani puri, and it may affect the gastrointestinal tract motility, and in turn it will affect the efficacy of the drug. Even there is a greater consumption of non-prescription drugs. See, old age people will be complaining like they are suffering from some kind of constipation or acidity, because of which they'll consume other non-prescription drug, like they may also take some multivitamin capsules for getting energetic and all those things. So these drugs, these non-prescriptional drugs, may interact with the prescription drugs, and because of which there will be a reduced efficacy, or there may be a chances of drug interaction also. And even there is a changes in gastric emptying, which is slow in older patient. This is age related problem. Now this is the problem encountered when a drug is being taken via the oral route. Next, transdermal route. Okay, the transdermal route of drug delivery has good potential for application in older patients, since it is simple to use by patients or their caregivers and may reduce the adverse effects, especially for the management of pain. No significant differences in absorption of drug from transdermal delivery system appears to exist between young and old individual. So transdermal route is quite good. Means there won't be any changes. The pharmacokinetic parameter of absorption, there won't be any changes for the transdermal route, either the person is an old person or a young individual. Next, regarding the subcutaneous route. Subcutaneous drug absorption is through the vascular capillaries and lymphatic channels. Molecular size primarily determines the passage across the capillary endothelium. The polypeptides of less than 5000 grams per mole primarily pass through the capillary pathway, whereas those of greater than 20,000 grams per mole primarily enter blood via the lymphatic pathway. Okay, so smaller molecular size, it will move to the capillary, little bit a bigger molecular size will move to the lymphatics. The skin blood supply and the lymphatic drainage changes with age. Okay, so thus you can say subcutaneous absorption of drugs may be affected with age and has clinical consequences. Okay, the subcutaneous route is of particular interest since it is the most common route of administration for therapeutic peptides and proteins, which become increasingly important in the therapeutic arena. Next, regarding the intramuscular route, you can say the intramuscular drug absorption is very similar to that of the subcutaneous route of drug absorption. Next, we'll talk about distribution. So, elderly have, as you compare to the young adults, there is a reduced lean body mass, reduced body water, increased fat as a percentage of body mass, decreased serum albumin and increased serum alpha acid glycoprotein. So this thing it is a characteristic of an old age person when you compare it with the young people. So loading dose need to be altered and even maintenance dose needs to be reduced because of the reduced clearance of the drug. So the plasma protein binding reduced due to reduction in the plasma albumin level and even changes in the binding affinity due to aging, because the lean body mass, the actual muscle mass, the muscle, the muscularity won't be there in old age people. Muscularity you will find in young people, but it won't be there in the old age people. Therefore the binding ability is also been reduced. So therefore dose of the drug should also be reduced similarly. Next we'll have there is a table regarding aging effect, means what all changes happens during aging and then how it will affect to the volume of distribution and few example of the drugs. So what all are the changes occurring in when you are aging? As you have seen previously in my previous slide, there will be a decrease in body water, decrease in the lean body mass, increased fat store, decreased albumin and increased alpha-1 acid glycoprotein. See, if you remember this albumin and alpha-1 acid glycoprotein, these both are the plasma proteins. Albumin is the plasma protein for binding of the acidic drugs, whereas the basic drugs mainly bind with the alpha-1 acid glycoprotein. Okay, both are the plasma proteins. Now in aging, the body water will be reduced. So what will happen to the volume of distribution? Yes, there will be decrease in the VD for hydrophilic drugs. Obviously, the volume of distribution of hydrophilic drugs will be reduced because there is reduced body water. If you have got 100 ml of water, so the entire drug will be incorporating into that 100 ml of water. So similarly is the case over here. The body water has been reduced, therefore the volume of distribution of the hydrophilic drugs will also be reduced. Next, there is a decrease in the body mass. We will have an example. First of all, ethanol and lithium, both are the example. Next effect is the decreased lean body mass. There will be a decrease in the volume of distribution for drugs that binds to the muscle, because the muscularity will be reduced. Example is digoxin. Next, there will be an increased fat store, therefore obviously increase in the volume of distribution for lipophilic drugs. Example is diazepam and trazodone. See, you can compare, body water is reduced and fat store is increased. Therefore hydrophilic drugs have got less VD and lipophilic drugs have got more VD. So what does it suggest? Yes, think about the dosing. If you want to prescribe a hydrophilic drug, you should prescribe more or less, or if when you want to prescribe a lipophilic drugs, how much dose you should give, more or less. Just think about this thing. Next, about albumin. The albumin level will be reduced and therefore there will be increased percent of unbound or free drugs. Okay, because the plasma protein cannot, means plasma protein is kind of a storage house of the drug. Okay, but the storage house is only very less. So most of the drug will be available in the free form. Example is the diazepam and valproic acid, both are acidic drugs. Next, there is an increase in the alpha-1 acid glycoprotein. So we can store large amount of basic drugs. So less percentage of unbound or free drugs available. Example is quinidine and propranolol. And yes, obviously both are basic drugs. So these are the effects of the aging on the volume of distribution of the various. Next, we have got two examples for distribution. Water soluble drugs like digoxin. Digoxin is a water soluble drug, and what happens in old age? The body water has been reduced. Okay. In elderly, the VD of digoxin is reduced, so smaller dose is required to provide adequate digitalization. Whereas for lipid soluble drugs like lignogen and thiopentol, these are highly lipid soluble drugs, VD rises, leading to increased half-life of a drug, increased drug effect and toxicity. So dose should be reduced for lipophilic drugs. Okay, so this is all about the distribution. Next, we'll talk about the drug metabolism. So here there will be a decrease in the hepatic macrosomal drug metabolism activity, decrease in the hepatic blood flow, and even for heart failure, alter the ability of the liver to metabolize drug by reducing hepatic blood flow. So for this you can say like the capacity of the liver to metabolize drugs not appear to decline consistently with age for all drugs. The greatest change are in phase 1 reaction, that is those carried out by the microsomal P450 system. There are much smaller changes in the ability of the liver to carry out conjugation reaction, that is the phase 2 reaction. Some of these changes may be caused by the decreased liver blood flow. There is a decline with age of liver's ability to recover from injury, like for example that caused by alcohol or viral hepatitis. Therefore, a history of recent liver disease in an older person should lead to caution in dosing with drugs that are cleared primarily by the liver even after apparently complete recovery from the hepatic insult. Finally, malnutrition and diseases that affects hepatic function like heart failure are more common in the elderly. Heart failure may dramatically alter the ability of the liver to metabolize drugs by reducing the hepatic blood flow. Similarly, severe nutritional deficiency, which occur more often in old age people, may impair the hepatic function. Variable changes in the first pass metabolism due to variable decline in the hepatic blood flow may have less first pass effect than younger people, but extremely difficult to predict as such. Acetylation and conjugation do not change appreciably with age. Oxidation metabolism through the cytochrome P450 system does decrease with aging, resulting in a decreased clearance of the drug. And lastly, you can say hepatic blood flow is extremely variable as such. Okay, so this is all about the drug metabolism. Next, we'll talk about the drug elimination. Renal drug clearance is the most consistent and predictable age-related change in pharmacokinetics. Renal functions, including the renal blood flow, glomerular filtration rate, and active renal tubular secretion process, all declines with age, increasing age. Renal tubular reabsorption also decreases, at least measured as glucose reabsorption, and appears to be parallel the decline of the GFR, that is the glomerular filtration rate. So measured GFR is the best overall indicator of renal function, but it is cumbersome to collect urine for extended period of time and is more prone to error of measurements. Okay. So diurnal variation in GFR and day-to-day variation in creatinine excretion may also contribute to error in GFR estimation. So what we are doing over here is we need to estimate, we need to calculate the elimination. So usually we concentrate upon the serum creatinine as such. It is the biomarker that we use in a lot of different equations, and none of them are very good. The one we use the most often is your Cockcroft-Gault equation. Okay, so Cockcroft-Gault equation is best way for calculation of serum creatinine, and thereby we can calculate the elimination of the drug. So why do we need to take care about the Cockcroft-Gault equation? There are two important reasons behind that. First one, it's relatively easy to calculate, and the second important reason is it's the basis for most of the drug dosing changes and adjustment that you are going to see in your career. So we'll have this Cockcroft-Gault equation which goes like this: 140 minus age in years into weight in kg divided by 72 into serum creatinine in mg per deciliter. So this calculation is for males, and for females we have got a correction factor, means same equation multiplied by 0.85. Okay, so accordingly what we assume that serum creatinine is equals to the GFR. But creatinine, where does this creatinine comes from? Creatinine comes from the muscles. But what happens in aging? The muscle mass, the lean mass is been reduced. So even the creatinine value may go down. Okay, and if you are prescribing a drug or means elimination, you are calculating with thinking that GFR is equals to the serum creatinine, then you may overdose a drug to that particular patient. So for old age patient, what we are doing is dosing should be done like you should start with low and then go slow. So this is about the elimination of the drug and changes in the elimination that takes place in old age people. Next we'll talk about the pharmacodynamic changes. Pharmacodynamics changes with age include receptor alteration, that is change in the number and sensitivity, impaired signal transduction and decreased homeostatic regulation. So you can say response decreases, like response to beta agonist and beta blockers is reduced due to reduced number of beta receptors. Sometimes response increases, like reduced sensitivity of baroreceptor, more chances of orthostatic or postural hypotension, because of which the old age person will fall down and there will be lots of fractures, and hence response to sedative, hypnotics and more respiratory depression, even intolerance to digitalis. So few drugs their response will be reduced, and for few drugs the response will be more. Okay, so we'll have two consideration. First of all, a decreased baroreceptor, and secondly increased sensitivity to the anticholinergic effects in the CNS. Okay, now we'll start with the decreased baroreceptor. So what happens to the baroreceptor? The stiff vessels do not adjust well. So older patients have blunted response with their baroreceptors. Blood vessels do not respond very well. So it is usually leads to falling off of the person, and there will be multiple fractures. So think of the medication that may affect your baroreceptor. Yes, these all are the medications that may affect your baroreceptor, like diuretics. What diuretics do? It will reduce the blood pressure. When the blood pressure is being reduced, what happens? The blood supply to various parts of the body will also be reduced. So ultimately our baroreceptor should get activated, and it should produce vasoconstriction, it should increase the heart rate, but everything is failing to happen because the beta receptors number is been reduced and the responsiveness also reduces. So when you are giving diuretics, it is more reducing the blood pressure, and our body is unable to maintain the homeostasis. Okay, means old age people normally they are suffering from hypertension, and then we are giving diuretics and number of antihypertensive drugs, but the hypertension will be reduced if the blood pressure has been reduced more than the normal, and because of which the person will more to hypotension and more fall in the blood pressure. Even BPH, benign prostatic hyperplasia, even this is the problem which is encountered in old age patient, and this also leads to reduction in the blood pressure, and even baroreceptor are unable to correct that thing. Cardiac medications, there are a number of cardiac medications and even erectile medications. All these medications, what they do, they will just dilate the blood vessels, and what happens when the blood vessels are dilated, the blood pressure falls, and our baroreceptor are unable to correct that falling blood pressure, because of which that person will fall off, because baroreceptors are unable to correct these things. Baroreceptors are not that much elastic in nature. The elasticity has been loosened in these baroreceptors. Next, the second thing, that is increased sensitivity to anticholinergic effects in the CNS. So geriatric patients mainly responds to anticholinergics by there will be a increased dry mouth, urinary retention, constipation, confusion and delirium. Okay, so these all are the side effects of anticholinergic drugs as such, but the old age people will respond too much to these anticholinergic drugs. And what all are the medications that may cause anticholinergic drugs? Yes, I have written it in a red color, that is antihistamines, overactive bladder agents, tricyclic antidepressants and muscle relaxants. See, normally the oldest people will be very much sensitive. Little bit they'll have an ice cream and they'll be suffering from cold. So for treating common cold, we'll give them antihistamines. Overactive bladder, these are the problem of the old age people, because of which we'll give some anticholinergics to reduce their bladder overactivity. Tricyclic antidepressants, most of the oldest people are suffering from depression, we give them TCAs, and which also have anticholinergic drugs. Even muscle relaxants have got anticholinergic drugs. So we give a little bit amount of these anticholinergic drugs and there will be huge response of dry mouth, urinary retention, constipation, confusion and delirium. So now there will be increased responsiveness over here. In our previous slide what I have showed you, here there will be a decreased responsiveness to the baroreceptor, and here the responsiveness is too much. Now we'll have an example. Suppose this is an old age person and a car hit him and the person falls off. So this person is now admitted in the hospital and he'll be given a list of medication. Suppose you are a doctor and you will prescribe drugs such as morphine for pain, Docetaxel to prevent constipation, diphenhydramine to ease congestion, and terms for acid reflux. Okay, now there is one question for you. Identify which medication may affect the geriatric patient differently than a young patient. Okay, you can think for a minute or for a few seconds. So the answer is morphine and diphenhydramine. Why morphine? Morphine is a water soluble drug. Okay, and even its metabolite, it have got an active metabolite, so may cause an adverse reaction. Okay, and moreover there will be an extensive CNS depressant by morphine. Whereas for diphenhydramine, yes, what kind of drug is this diphenhydramine? Diphenhydramine is an anticholinergic drug. So what I have told you, anticholinergic drugs, the responsiveness of anticholinergic drugs for this geriatric patient will be too much. So always you should keep in mind upon all these pharmacokinetic and pharmacodynamic changes taking place in that old age person's body, and then you should prescribe the drug. I hope you people understood this video about drug dosing in elderly person. Thank you for watching my video.